Alzheimer's disease is a progressive form of senile dementia, leading to a complete loss of cognitive abilities, developing mainly after 60 to 65 years. Clinically manifested by a gradually arising and constantly progressive disorder of cognitive abilities, attention, memory, speech, praxis, gnosis, psychomotor coordination, orientation, and thinking. To diagnose Alzheimer's disease allows a thorough collection of anamnesis, PET of the brain, the exclusion of other types of dementia using EEG, CT, or MRI. Treatment is palliative, includes medication, cholinesterase inhibitors, memantine, and psychosocial, art therapy, psychotherapy, sensory integration, simulation of presence, therapy. Reasons. Until now, the etiopathogenesis of Alzheimer's type dementia remains a mystery to scientists and practitioners in the field of medicine. There is no connection with any external factors that trigger Alzheimer's disease. The only known morphological substrate of the disease is the formation of intraneuronal neurofibrillary plexuses and cerebral clusters of beta amyloid, the so-called senile plaques, which leads to degeneration and death of neurons. There is also a decrease in the level of cholinacetyltransferase. These features form the basis of three main hypotheses trying to explain how Alzheimer's disease develops. Older is the cholinergic theory of the onset of the disease, linking it with a deficiency of acetylcholine. However, the results of clinical studies have shown the inability of acetylcholine drugs to at least partially or temporarily stop Alzheimer's disease. The amyloid hypothesis of the development of the disease has existed since 1991. According to it, the basis of pathology is the accumulation of beta amyloid. Interestingly, the gene encoding the beta amyloid precursor protein is part of chromosome 21, the trisomy of which underlies Down syndrome. At the same time, in all patients with Down syndrome who have reached the age of 40, an Alzheimer's-like pathology is observed. Predisposing factors for the synthesis of pathological beta amyloid are called the insufficiency of mitochondrial oxidation processes, a more acidic reaction of the intercellular medium, and an increased number of free radicals. Deposits of pathological amyloid are noted both in the cerebral parenchyma and in the walls of cerebral vessels. It should be noted that such deposits characterize not only Alzheimer's disease, they are observed in cerebral hematomas of congenital genesis, Down syndrome, and in normal aging processes. According to the third hypothesis, Alzheimer's disease is associated with the death of neurons as a result of the accumulation of hyperphosphorylated tau protein in them, the threads of which stick together and form tangles. According to the tau hypothesis, the accumulation of protein is associated with a defect in its structure. The formation of plexuses causes the disintegration of intraneuronal transport, which in turn leads to a violation of the transmission of signals between neurons, and then to their destruction. On the other hand, the formation of neurofibrillary tangles is also observed in other cerebral degenerations, for example, in progressive supranuclear palsy and frontotemporal atrophy. Therefore, many researchers deny the independent pathogenetic value of tau protein, considering its accumulation a consequence of the massive destruction of neurons. Among the possible causes that trigger Alzheimer's disease is the synthesis of pathological apolipoprotein E. The latter has an affinity for amyloid protein and takes part in the transport of tau protein, which may underlie the typical morphological changes in the disease described above. 5 main genetic sites with which the development of the disease is associated have been identified. They are located on chromosomes 1, 12, 14, 19, and 21. Mutations in these loci lead to disturbances in the protein metabolism of cerebral tissues, entailing the accumulation of amyloid or tau protein. In typical cases, Alzheimer's disease manifests itself in persons older than 60 to 65 years. It is extremely rare to find cases of an early form of the disease that occur in the period from 40 to 60 years. Dementia of the Alzheimer's type is characterized by an inconspicuous and prolonged onset, steady progression without periods of improvement. The main substrate of the disease is disorders of higher nervous functions. The latter include short-term and long-term memory, attentiveness, spacetime orientation, psychomotor coordination, praxis, the ability to perceive various aspects of the external world, gnosis. Speech, control and planning of higher neuropsychic activity. Alzheimer's disease is divided into 4 clinical stages: pre-dementia, early, moderate, and severe dementia. Pre-dementia. At the stage of pre-dementia, subtle cognitive difficulties arise, often detected only during detailed neurocognitive testing. From the moment of their appearance to the verification of the diagnosis, as a rule, 7 to 8 years pass. In the vast majority of cases, memory impairments on recent events or information received the day before come to the fore, significant difficulties in remembering something new. Some problems with executive functions. Cognitive flexibility, the ability to concentrate, planning, abstract thinking and semantic memory, difficulty remembering the meaning of certain words, usually go unnoticed. At the stage of pre-dementia, apathy may be observed, which is a typical neuropsychiatric symptom that is persistently present at all stages of the disease. A number of authors refer to this stage as mild cognitive disorders. Early dementia. Progressive deterioration of memory leads to such pronounced symptoms of its violation that it becomes impossible to attribute them to the processes of ordinary aging. As a rule, this is the reason for the assumption of the diagnosis of Alzheimer's disease. At the same time, different types of memory are disturbed at varying degrees. The most affected is short-term memory, the ability to remember new information or recent events. Aspects of memory suffer little, such as unconscious memory of previously memorized actions, implicit memory. Memories of distant life events, episodic memory, and facts learned once upon a time, semantic memory. Memory disorders are often accompanied by symptoms of agnosia, impaired auditory, visual, and tactile perception. In some patients, disorders of executive functions, apraxia, agnosia, or speech disorders come to the fore in the clinic of early dementia. The latter are characterized mainly by a decrease in the pace of speech, impoverishment of vocabulary, weakening of the ability to express one's thoughts in writing and orally. However, at this stage, during communication, the patient quite adequately operates with simple concepts. Due to praxis disorders and movement planning when performing tasks using fine motor skills, drawing, sewing, writing, dressing, the patient has a clumsy appearance. In the stage of early dementia, the patient is still able to independently perform many simple tasks. But in situations that require complex cognitive effort, he needs help. Moderate dementia. Progressive inhibition of cognitive functions leads to a significant decrease in the ability to perform independent actions. Agnosia and speech disorders become apparent. Paraphasia is noted, the loss of the grammatical structure of speech and its meaning, since instead of forgotten words, patients are increasingly using incorrect words. This is accompanied by a loss of writing skills, dysgraphia, and reading, dyslexia. The growing disorder of praxis deprives the patient of the ability to cope even with simple everyday tasks, such as dressing and undressing, eating independently, etc. In the stage of moderate dementia, there are changes in long-term memory, previously unaffected by the disease. Memory impairment progresses to such an extent that patients do not remember even their closest relatives. Neuropsychiatric symptoms are characteristic: emotional lability, sudden aggressiveness, tearfulness, resistance to care, possibly vagrancy. Approximately one-third of patients with Alzheimer's disease have a syndrome of false identification and other manifestations of delirium. There may be urinary incontinence. Severe dementia. The speech of patients is reduced to the use of individual phrases or single words. In the future, speech skills are completely lost. At the same time, the ability to perceive and maintain emotional contact with others is preserved for a long time. Alzheimer's disease in the stage of severe dementia is characterized by complete apathy, although sometimes aggressive manifestations can be observed. Patients are exhausted both mentally and physically. They are unable to perform even the simplest actions on their own, have difficulty moving, and eventually stop getting out of bed. There is a loss of muscle mass. Due to immobility, complications such as congestive pneumonia, pressure sores, etc. It is the complications that ultimately cause death. Diagnostics. One of the main directions of diagnostic search is the collection of anamnesis and complaints. Since the patient himself in the early stages of the disease often does not notice the changes occurring with him, and with the development of dementia cannot adequately assess his condition, the survey should be conducted among his relatives. Important are the inability to accurately determine the onset of cognitive abnormalities, indications of the gradual and steadily progressive nature of the aggravation of symptoms. The absence of a history of cerebral diseases, encephalitis, intracerebral tumor, brain abscess, epilepsy, chronic ischemia, transferred onc, etc. and craniocerebral injuries. Diagnosing Alzheimer's disease in the pre-dementia stage is quite difficult. During this period, only advanced neuropsychological testing can reveal some disorders of higher nervous functions. During the study, patients are asked to memorize words, copy figures, perform complex arithmetic operations, read and retell what they read. In order to exclude other diseases that can lead to the development of dementia, the neurologist conducts a neurological examination, prescribes additional examinations, EEG, REG, echo EG, CT or MRI of the brain. Of particular importance in confirming the diagnosis is the detection of beta amyloid deposits during PET of the brain with the introduction of the Pittsburgh composition B. Recently, it has been proved that another marker of the disease can be the detection of tau protein or beta amyloid in the cerebrospinal fluid taken for analysis by lumbar puncture. Differential diagnosis of dementia of the Alzheimer's type is carried out with vascular dementia, Parkinsonism, dementia with Lewy bodies, dementia in epilepsy and other neurological pathology. Treatment of Alzheimer's disease. Unfortunately, the currently available treatments are unable to cure Alzheimer's disease or slow its course. All attempts at therapy are essentially palliative and can only slightly alleviate the symptoms. The most recognized drug regimens include memantine and anticholinesterase drugs. Memantine is an inhibitor of glutamate receptors, excessive activation of which characterizes Alzheimer's disease and can lead to the death of neurons. There is a moderate effect of memantine in moderate to severe dementia. When taking it, side effects are possible: dizziness, confusion, headaches, hallucinations. Cholinesterase inhibitors, rivastigmine, donepezil, galantamine, have shown moderate efficacy in attempts to treat Alzheimer's disease in the early to moderate stages of dementia. Donepezil can be used in severe dementia. The use of cholinesterase inhibitors in the pre-dementia stage could not prevent or slow the development of symptoms. The side effects of these medications include bradycardia, weight loss, anorexia, muscle spasms, gastritis with high acidity. In cases where Alzheimer's disease is accompanied by antisocial behavior, antipsychotics may be prescribed to stop aggression. However, they can cause cerebrovascular complications, additional cognitive decline, movement disorders, and, with prolonged use, increase the mortality of patients. Along with pharmacological methods, psychosocial methods of treatment of patients with Alzheimer's disease are used. So, supportive psychotherapy is aimed at helping patients with early dementia to adapt to their disease. In the stages of more severe dementia, art therapy, sensory room, memory therapy, presence simulation, sensory integration, validation therapy are used. These techniques do not lead to clinically significant improvement, however, according to many authors, they reduce the anxiety and aggressiveness of patients, improve their mood and thinking. Prognosis and prevention. Unfortunately, Alzheimer's disease has a disappointing prognosis. The steadily progressive loss of the most important functions of the body leads to death in 100% of cases. After diagnosis, life expectancy averages 7 years. Less than 14% of patients live for more than 3 years. Since Alzheimer's disease is an important social problem in developed countries, many studies have been conducted to determine the factors that reduce the likelihood of its development. However, such studies provide conflicting data, and there is still no solid evidence of the preventive significance of at least one of the factors under consideration. Many researchers tend to consider intellectual activity, love of reading, passion for chess, solving crossword puzzles, mastery of several languages, etc., as a factor that delays the onset of the disease and slows down its progression. It is also noted that the causative factors in the development of cardiovascular pathology, smoking, diabetes mellitus, increased cholesterol, arterial hypertension, cause a more severe course of dementia of the Alzheimer's type and may increase the risk